Thank you, Dr. Nasser. Now I may present Dr. Amer Derazi, who is consultant bariatric and laparoscopic surgeon. He's one of the important people in the bariatric surgery in Bahrain. Dr. Amer, the floor is yours, please.
Thank you very much for your kind introduction. I'd like to thank the organizing committee and Dr. Ram for this kind invitation to present this talk. I think it's very important to engage amongst us between surgeons and endocrinologists. I mean, at the end of the day, we care about the benefit for the patient, and I think we can achieve best results by collaborating rather than fight amongst each other. So my talk today is going to be about metabolic surgery, the evolution and efficacy. So this is the agenda for today. Let's talk initially about how these surgeries came about. These are the commonly performed surgeries. I mean, I prepared this for non-surgeons, so I'm not going to talk much about the technicality unless somebody wants to ask. So the gold standard so far has been Roux-en-Y. Now the commonest surgery being performed is the sleeve hysterectomy. Bands, we're abandoning them, and we talk about PBD for the super obese. So when did the metabolic surgery come about? Well, let's talk about bariatric surgery. Bariatric surgery first came about since the 50s. Each decade there has been an evolution in bariatric surgery. Initially we were talking about intestinal bypasses. Then the decades afterwards we moved into gastric bypasses, followed by the bands, sleeves, and then in the 2000s we started doing the laparoscopic surgery. So when did the term metabolic surgery come into light? Well, it all started with this article. This article came about in '95 by Porras. Basically, he was doing an audit on his bariatric patients, and what he noticed is that a lot of his patients, the biochemical profile, the ones that were diabetic, their biochemical profile improved drastically to the extent that some of them did not need any hypoglycemic agents. And at the time, they were talking about would these surgeries cure diabetes? And here I have to emphasize that currently we do not talk about curing diabetes, we talk about inducing remission, because we know that the effect of surgery is not lifelong. I mean, we can only induce remission for so long. Some patients might be lucky enough to have 10, 20 years of diabetes-free life, but then even that is important, and I'm going to talk later about that. So after the 95, this concept started to move slowly up to the 2000, where it started to pick up by different societies worldwide. And I'd say it was only in the last 2 to 3 years that the term metabolic surgery started to make it into the guidelines worldwide. So again, we were doing bariatric surgery, wanted to improve life and reduce mortality, and now we're talking about doing these procedures to resolve diabetes. The way I think about it is that obesity and type 2 diabetes in specific are basically two faces of the same coin. I mean, they fit, they're jigsaw pieces that fit in the same puzzle. You treat one, you improve one, you improve the other. So in short, with this introduction, I hope I can leave you with two things. We know that bariatric surgery, now we do it for people that are morbidly obese, so BMIs of 45 and above, or 35 with certain comorbidities. Whereas the term metabolic surgery is more reserved for lower BMIs, so people with overweight or obesity and type 2 diabetes. So the outcome in metabolic surgery is improvement in the sugar level rather than losing weight. So how does these surgeries improve diabetes? I mean, if you ask anyone, they'll always say reduce insulin resistance. Yes, that's probably what happens later on, but we notice that when we do these surgeries, the biochemical profile improves from the first week. So the resistance is not fully explaining that. So this was published in Nature magazine. So I hope this comes. All right. Yeah. So basically what happens is the bolus goes into the small pouch, especially this is a gastric bypass. What happens is the load goes into the ileum quite rapidly, the ileum starts secreting the GLP, PYY, oxy, and increased bile acids. This in turn will act on a number of organs. So first it will act on the pancreas, therefore increasing insulin release, reducing glucose. It will also act on the adipose tissue. So in the white adipose tissue in specific, it will reduce the inflammation, yes, and therefore the resistance. However, it will also act on the brown adipose tissue where it will increase the thermogenesis, so diet-induced thermogenesis. Finally, these hormones will affect the brain where they're going to reduce the intake and increasing the food reward in the hedonic system. So the patients will not seek food. I love this diagram because it illustrates these changes a long time. So the early changes versus later changes. So the initial effect is mainly by the effect of energy restriction on the liver, reducing the gluconeogenesis. Intermediate effect is on the pancreas. The peripheral tissue resistance is usually late. It happens months later down the road. Having said that, again, going back to metabolic surgery and how it affects the world, I mean, all endocrine societies worldwide have adopted metabolic surgery as a form of combating type 2 diabetes. So we're talking about the American Diabetic Association, the European Association for Diabetes and Metabolic Surgery. All of them, you will find this paragraph. So surgery, metabolic surgery should be considered in diabetic patients with a BMI of 30 and uncontrolled diabetes. And therefore, this diagram that you will see later. Who should we consider for these surgeries? Again, somebody who fits the previous mentioned criteria, and they need to have acceptable risk. Keep in mind that defining success in this type of surgery depends on glucose level. This is one thing that's important to do, especially if we're going to embark on metabolic surgery in thin patients. We need to classify them. As I mentioned earlier, we know that not everybody will benefit. There are people that will not benefit from metabolic surgery. So how do we know who will benefit and who will not? There are a number of predictive scoring systems. The DIREM scoring system is one of the most quoted system. However, in the Asian population, there is something called the ABCD score by a close friend of mine who invented it, Professor Weiji from Taiwan. However, this is the most quoted scoring system. It depends on the age of the patient, level of HbA1c pre-op, presence of other diabetic medications, and if insulin was started. A number is given assigned to each one of them, and then the total score will give you the probability of inducing type 2 diabetes remission after surgery. So if you can see from this, the lesser the number, the better the chance. So if you have up to 6 in the DIREM score, you have an 80% chance of having diabetes remission for up to 10 years. 10 years of no diabetic medication, 10 years of no complications. So that in itself is good. But if you do the scoring and you find that your patient is actually 20 or 10 and above, then their probability of having a type 2 diabetes remission is very low. So if you weigh the risk and benefit of this procedure, maybe you will not embark on that journey. Of course, the same contraindication of bariatric surgery work for metabolic surgery. So we're not going to do it for people that are alcoholics or drug abusers. Type 1 diabetes, we cannot cure, of course, with surgery because islet cells are not there. We will not do anything by doing this surgery. So, how does the surgery affect diabetes? First of all, I'm going to present this fast slide about the SOS study. This is the Swedish OB study, which is the longest study that followed up bariatric surgery patients for up to 20 years. It clearly highlighted that for weight loss, surgery is superior, and gastric bypass drops the weight more than anything else. But when we look at surgeries that, at studies that focused specifically on improvement of diabetes, these are 5 of the most important studies. These are longitudinal studies, prospective studies that followed patients up to 10 years. So if you can see for each study, you will find 2 columns. The first column is the outcome, type 2 diabetes remission after 2 years. The second column is type 2 diabetes remission after 10 years. So first thing to notice is the first column in each study is high. You're talking about between 70 to 90% type 2 diabetes remission at 2 years, which is quite high. But if you look at the second column, we notice as time goes on, the column drops. Some people will regain their diabetes. They will regain their weight. They will regain the diabetes. However, having said that, even after 10 years, we're talking about a 36 to 50% of type 2 diabetes remission, which I think is quite good. What about randomized controlled trials? I mean, everybody will say, oh, this is prospective. This was the first trial that came into light. I mean, a close friend of mine, Phil Schauer from Cleveland, did this study. So they randomized patients into intensive medical treatment versus 2 types of surgery, and they followed them up for up to 5 years. And as you can see, intensive medical treatment was inferior to surgery in the amount of HbA1c reduction. It clearly demonstrated that. Moreover, there has been a number of trials after that. This is a meta-analysis of all the trials that looked into metabolic surgery versus intensive medical treatment. I think around 11 trials. And all of them show the superiority of metabolic surgery when it comes into the reducing HbA1c in these patients. There was a misconception before that the heavier the patient, the better the outcome. Because they're so fat, then yeah, let's consider metabolic surgery only for those who are BMIs 50 and above. So in this meta-analysis, what they did is they divided studies that looked into BMIs below 35 and those that looked into above 35. And the outcome was the same. So now we know that the effect on diabetes is the same, whether the patient is super obese or if they're just overweight or like class 1 obesity. So this opened the door to considering surgery, metabolic surgery in thinner patients. Let's put it to you this way. Then comes the DSS summit. I mean, everywhere, any guidelines you will read right now, whether endocrine or surgery, that's what they will refer to. This was one of the biggest consensuses out there. They brought around 48 societies, worldwide societies. The majority of the people attending this were endocrinologists and internists, actually. Only less than 10% were surgeons, because people say surgeons are driving this. No, it was the endocrinologists who were pushing for this, actually. So they looked into all the literature that is out there, and they came up with these 2 diagrams. So if you can see the diagram to the left, they concluded that intensive medical treatment drops HbA1c after a while by roughly 1% in average, whereas metabolic surgery drops it by 2%. And these are the included study in their meta-analyses, but I mean, this was done by all these people, and they came up with this. So now we know that metabolic surgery works for reducing HbA1c. The question is, does it reduce the long-term complications of diabetes, even if diabetes recurs? And this is where these 2 studies that I will present, that's what they looked at. So first of all, this was a continuation of the SOS study. So first, they looked into the presence of microvascular complications. Microvascular complications being retinopathy, nephropathy, and neuropathy. And they followed the incidence of these complications over 10 years in patients who did surgery. So we know that these complications happen even after surgery. But how do they compare when we look at patients that did not do surgery? That's how they compare. So here, these patients in red are obese patients that underwent surgery compared to their counterparts that did not undergo surgery, and they were continuing on intensive medical treatment. So up to 20 years, we see the divergence. There is a 50% reduction in microvascular complications, even if type 2 diabetes was in remission for as little as 3 or 4 years. The beneficial effect on the microvascular complication persists for up to 20 years. So people started saying, okay, you're talking about microvascular complication, what about macrovascular complication overall? So again, the SOS study looked into their data. This is basically a graph for all the complications put together, micro and macro complications, we see again superiority of the surgery group even up to 16 years. The same graph was divided into micro and macro vascular complications, and still we can see that the effect is the same on the two. Someone started questioning, when you look at microvascular complication, is the effect the same? Is the effect the same, i.e., on retinopathy, neuropathy, does it affect all of them individually in a similar way? Therefore, this was the study done by O'Brien. So first, he looked into all microvascular complications. You can see the same diversion, protective effect. And then he looked into individual micro complications. So definite effect of retinopathy up to 7 years. Definite effect, neuropathy up to 7 years, definite effect on retinopathy, definite effect on neuropathy. So each individual vascular complication improved. The question then comes, are these surgeries safe? I mean, my colleague from Saudi highlighted that these surgeries are not simple. There are complications, there are mortality, and people talk a lot about these surgeries as it's the end of the world, like people who do bariatric will die. This is simply not true. It's a misconception. First of all, let me tell you the beneficial effect on long-term mortality for patients. So if somebody is diabetic and they continue on their path versus if they're obese and diabetic and they do the surgery. If we do the surgery, mortality improves by around 89%. So people will live longer. And this is not my word. This is taken from, again, the SOS study that followed patients for up to 20 years. It's data. It's been replicated by a number of studies. We know that by doing surgeries and losing weight, I mean, it's not the surgery, it's the weight loss. They avoid the complications, the micro and macrovascular complication. Therefore, they end up living longer. So again, going to how safe it is. There was a couple of studies in the US. They looked into database searches. They looked into diabetics that underwent operations, bariatric operations. So they found the overall mortality was 0.3%. So less than 1% even, which is very low compared to other procedures. Another meta-analysis looked into a number of databases, a total of 85,000 patients. Again, same mortality, 0.3. It seems that this is the magic number. So how does this compare to other types of surgeries, diabetics undergoing other types of surgeries? You can see that mortality from Roux-en-Y, for example, is the same as an arthroplasty. It's the same as a lap epi, marginally less, but I would call the same. It's the same as a lap chole. We don't hear people complaining about death after lap chole, but we hear a lot about people complaining of death after a bariatric surgery. But if you look at the numbers, it's the same. The mortality is much less than lap colectomies that we're doing a lot nowadays. Again, nobody talks about that. What about complications? So people might not die from this, but we will talk about the leak, we will talk about the bleeding. Again, the same database. This was a blinded database search. They looked into the overall rate of overall complications. It was found that Roux-en-Y complication was around 3%. It was the same as a lap hysterectomy, lap chole, lap epi, which are the commonest surgeries out there. And again, nobody talks about complications in these surgeries, but it's a big thing when something happens to a bariatric patient. For the type of surgeries, I mean, I'm just going to have a couple, I'll just run through this because unless somebody is interested. We just have to emphasize that not everybody should undergo this surgery, and it is not the surgeon who decides who undergoes this surgery. It needs to be a multidisciplinary team. The surgeon, the endocrinologist, nutritional specialist, dietitian, preferably a psychologist or a psychiatrist. This MDT should discuss the patient, see the case, review it, and unless every single person agrees, they should not go further. I mean, that's what we practice in Salmania. I know it's the same in BDF. I'm pretty sure KHUH and other centers do the same thing. This is the trend internationally. We need to assess their nutritional status, mental status, and functional status. Just two things about the types of bariatric surgery. There are restrictive procedures by which we make stomach smaller, and then there is a combined restrictive and malabsorptive procedure. Examples of the restrictive procedure is gastric banding or sleeve gastrectomy, which is the commonest thing. Examples of the combined procedures are bypasses and PPDs. We have to emphasize that if somebody is looking for metabolic surgery, combined restrictive and malabsorptive procedures give a better biochemical profile. So maybe that would be the way to go instead of going for restrictive procedures. These are the procedures. A few words about the complications. As I said, complications is less than 3%. We're talking about leaks, bleeding, DVTs. I would say that the #1 killer in these patients, despite being very rare, is a DVT. PE and DVT. So that's why currently the guidelines is anyone undergoing bariatric surgery, we give them DVT prophylaxis for up to 3 weeks, injectable. We're talking about dumping syndrome, internal herniation. I mean, these are things that we can manage. Keep in mind, with massive weight loss, 30% of your patients will develop gallstones. So we need to keep that in mind. With this, I shall bring my talk to an end. I just want you to focus on the following points that I tried to highlight. Metabolic surgery should now be considered for adults with a lower BMI range and the existing of comorbidities. Metabolic surgery gives the following benefits: significant reduction in mortality, it aids in remission of type 2 diabetes, and this is the most important point, it lowers the overall incidence of micro and macrovascular diseases, complications of diabetes. Planning of metabolic surgery requires careful assessment of the different aspects, preferably through an MDT. With that, I shall bring my talk to an end, and the floor would be open for comments or questions. Thank you very much.